Only this. A lot of roses. I used to cut them.
Yes.
My wife,
Yeah.
until the stupid cats started knocking them over. Every day. Get over and start eating the roses.
Yeah.
I used to knock all the thorns off.
Yeah, that's exactly
Right.
Every weekend I have,
What did you say? This?
yeah, the cat was more important than,
I'm removing these note takers that keep popping up.
Thank you. Your daughter's having an event tomorrow. I'll be there.
Okay.
Yeah,
Well, we have.
it was really fun last week. Yeah.
We can share some.
You can what?
We can share.
Oh, yeah. That'd be great. Yeah.
Yeah.
Yeah. Absolutely.
Yeah.
Yes.
There we go.
Oh, great. I'm fine. That every time.
I'll have to adjust it because we have to do a workaround tonight. So I'll have to just move it around as we talking. We're fancy.
So you can have the old Mr. Microphone then?
You can still use your microphones. Yes.
This one, it seems to be pretty good at picking up audio.
It really does.
We use it in meetings and it's about the same. People making public comment, hopefully we'll just use the microphone though.
Okay, making sure the note taker's not there again.
So now the meetings are very, very locked down.
I was trying to see. Well, Emily got it. Maybe she. Oh.
Whenever you're ready, I'm ready to go.
Is Dion?
I don't see D yet.
Okay, and do you know if Emily is representing Lucas?
I believe so. She said she was attending. Oh, she is here. Here.
Okay, can you just let me know when Dee joins?
Yep.
All right, thanks. All right, we'll get started. Thank you for coming, everybody. Before we get to approving the agenda, I just wanted to welcome everybody. Make sure that we. I'm just waiting to see if Dee joins. Dee is supposed to be.
That might be for West Sacramento.
Okay.
That might be.
Oh. Is that? Okay. So we'll go ahead and get started. I'd like to thank everybody from the community for coming and Yolo County staff for coming, and our guests, and for everybody that's online. And I am assuming that Emily is here representing the Board of Supervisors, and thank you for attending. And before we get to the approval of the agenda, I just wanted to make sure we're have some structure around public comment. We have some new members. We have members of the public on Zoom, and I just want to make sure that everybody knows that at every beginning of a new topic, there is an option for public comment. So there's plenty of options for public comment throughout the meeting. You are also not required to identify yourself. If you choose to, that's fine, but you're not required to identify yourself. I also just want to remind everybody around the Brown Act, and that if something is brought up in public comment that is not on the agenda, we will not be entertained. There won't be any discussion on that or decisions. However, if the board members would like to, or county staff would like to ask for clarification, or would like to ask for the staff to look into something, that's fine. And also we can certainly put that item on the agenda for next. Any questions? No. All right. We also have the Oliveras is participating remotely under the under AB 2449. I just need to verify, Dee, that you meet the requirements under 2449 and that you do not have anybody in the room with you that's over 18.
Correct.
Thank you. All right. Anybody else that we have that's online from the board? Okay, great. All right. So now approval of the agenda.
A second.
Great.
Gotcha.
Everybody in favor? Anybody opposed? Okay, motion carries. And we'll move on to approval of the minutes from the 10:15 meeting. We were on break in November.
And I sent 2 corrections to Christina, one to Lou Ang's name and one to the spelling of David Rosenberg's name. So move to approve with those corrections.
I'll second.
All right. Everybody in favor?
Aye.
Anybody opposed? All right, motion carries. Great. All right, so I just want to, before I go to the chair report, I want to welcome the Health and Services new director, Monica Morales. Welcome. Not to put you on the spot, but if you'd like to take a few minutes to share, you're welcome to.
Thank you. I appreciate you guys being here this late at night, and it's cold, and it's starting to just change the weather, so thank you. I am 6 months in. I started my 6 months this week, so I'm relatively new. I'm originally from the Santa Cruz area. I was raised in Watsonville, and so I've been kind of going into different kind of groups, so apologies if I haven't been here. It's been quite busy, as you can imagine, but I'll share a little bit about my history. I started doing a lot of work in community-based organizations. I started in clinics and helped with different CBOs. Yeah, I left to Nevada for a couple years, and where I started my state work, seeing the public health programs in the state of Nevada. I was there for about 6 years, and then I came to the California Department of Public Health, where I oversaw a lot of the also community programs. That's where I started the substance use and addiction branch and launched the Office of Suicide Prevention. And that's when we were barely starting to enter into the behavioral health prevention space. So I was very, some programs excite you more than others. And so those are some of the areas that I was really thrilled to be working on at the state level. And then I ended up going back home. I did not plan to go back home. I just got a few phone calls that they were looking for a health director at the county level. So I went back home. I ended up getting the job. I went back home, and I was there in Santa Cruz for the past 3.5 years. And long story short, for many reasons, I ended up wanting to come back to the Sacramento area. So ended up applying for different jobs, and I felt that YOLO really fit what I wanted, the communities that I wanted to work with. The profile is very similar to Santa Cruz. except without the beach. But there's, we have a UC, it's an agriculture community, we have, just the diversity of the population and the economics. So here I am still learning a lot, but it's a very tough and exciting time. Right now, I don't know how many of you guys remember the space of behavioral health 10 years ago, but it looks very different. And the opportunities that we see now, although it's a huge, lift, that we did not have reimbursement for transportation. We did not have reimbursement for some of the housing work that we're able to do now. We did not have the ability to work with like CHWs and, so it's just a lot to take all at once. And it didn't help that we had COVID. But at the state level, I was working on some of the initial design for BHSA. And so now just kind of seeing it at this level it's hard. It's very different. But I'm thrilled to be here. My first kind of 3 priorities, as you can imagine, is to support the staff. I will say I ran the behavioral health program in Santa Cruz too. And when I look and compare, because it's about the same size, you're completely understaffed here. I had about almost 300 staff in Santa Cruz just for behavioral health. And how many do you have, Tilly?
I think something like 90.
Yeah, and it's the level of need is the same. The clientele, is about the same. And so just kind of having a view and being here and understanding how much support the staff really need is really important to me. Obviously, I'm still learning a lot and getting a sense of what the needs are. The budget is happening across the state. So I left Santa Cruz with a $13 million deficit just for behavioral health as well. So I submitted the budget to the board with a $13 million deficit. And so it's tough times right now. I think what's hard is that we don't have anything to lean on here. So we'll have to get creative so that we don't have general fund, we don't have any other grant. But there are opportunities that I'm noticing already in terms of, how do we get better at billing? How do we think about all the activities that our staff are doing, getting more creative to just act in some form and type of code that we can for Medi-Cal billing. So that's obviously my first priority now is definitely, second priority, is balancing the budget. But I think third, it is the opportunity to be able to say it's tough. But I think if we put the client at the center of all of this, that's the intent. As hopefully we get through some of these more mistakes and better understanding from the state of how we can do this better. So I'm glad to be here to meet you guys. Thank you for everything that you're doing. You are a key component to the approach and the vision that we have in the community. And so my goal is just to continue to work with you as needed to kind of get through the next. I thought, Tony, it's going to take us 3 years really to just feel a little bit at ease. Not everything perfect, but just a little bit more at ease. So I'm here to answer questions if you have any, and I'll be joining as I'm able, either through Zoom, the meetings, just to kind of learn from you as well. So that's it, a little bit about me.
Thank you. Thank you. Thank you. I was so excited that you were here, and I'm so excited. I blew right past public comments, so I'm going to back up and I'm going to open it up to public comments. Is there anybody on the line?
See no hands up.
All right, thank you. All right. Okay, so we also have a new member, Kenya Gallo. Had the pleasure of meeting with her briefly just to start our onboarding process that we're super excited about. And Kimberly's going to do the rest, which, thank you. And so welcome. We're really excited to have you. We're really looking forward to having you part of the conversation, and we're all excited that you're choosing to serve the community in this way. So welcome. And if you also want to share some more, you're welcome to.
Yeah, I'll briefly share. My name is Kenya Gallo. I've
been a resident of Yolo County my whole life, with the exception of college. I was San Jose State, and what really drew me to the local behavioral health board was my own personal crisis and the availability of resources in Yolo County. So want to share that that the resources that are available help me a lot, and I want to make sure that it's accessible for everyone, and that's kind of what led me into joining the board. So thank you, everyone, and thank you for the onboarding as well.
And we're looking forward to getting your, since you'll be the first one to go through it with Kimberly, so I'm sure look forward to hear your perspective on that as well. So thank you. All right. Okay, so I'm going to try to get through this without tearing up, because the next thing on the agenda is farewell to Mary Seaman, who has been here since 2019. And it's bittersweet. We're excited that she's moving to do something she really wants to do. But we've really, she's benefited the board in so many ways in the community, and we're so passionate. We're just going to miss everything that she brings to the table. I have a whole list here of all of her accomplishments, which is pretty amazing. And so I can't list them all. There's not enough time. But I think in a nutshell, you know, Maria's been an integral part of strengthening the board, especially since 2019. She was vice chair up until this last term. And during that time, her engagement with committees and participating in our fee process are just a few of the many things that she was passionate about and getting involved in that really made a difference. You know, you just, it just struck me, your leadership, you just, you know, elevated the voices of people who are living with mental illness and behavioral health and substance use issues. And I think personally, I'm grateful for your steady presence, your leadership, you know, your thoughtful comments that help us maybe think about something a little bit different than maybe where we're headed. And so I really appreciated that. And your unwavering commitment to transparency is also something, and inclusion, which I think has left a meaningful impact on how we're serving our community. So thank you from the bottom of my heart. I'm so grateful for your years of service, your partnership, and your passion, and I'm sure everybody else feels similarly. And so with that, we're grateful for your willingness to kind of stay on for a few months, even though I know it's been tough with everything you've got going on. With that, I'd like to open the floor to any board members who might want to share, or anybody from.
I'll go. I attended addiction intervention court graduation last month.
Sorry.
I was
That
about
wasn't
three.
clear. Sorry, I wasn't clear, but
You're
you
making me
got it.
blush now. Everyone's gonna see it's being recorded. Okay.
Maria has been a truly amazing advocate. And she has always been willing, when I was chair, to step in and do things that, you know, maybe everybody wouldn't want to do. But she's done them, and she's done them well, and she's just been a real backbone. I'm truly gonna miss her. Well, I will be joining her in retirement soon. But we're gonna miss you, and I think you've done a terrific job.
On top of what other people have said, I just want to add how much it meant to me when we were officers together. We could just talk things through together, and you were always just wonderful. And I hope we can continue our friendship. Yeah. Thank you.
Thank you for a very nice one. I do appreciate it. It has been a pleasure to serve on this board. My decision to serve came from a very personal place. I have family members with mental health, and I also work for Sutter. And so just seeing the different needs really made it something that I was passionate about. Unfortunately, my day job is taking up so much of my time that I'm finding I can't keep going, so. But I appreciate that, you know, people like Kenya and others are stepping up to serve the board. It's important work. And I'm glad Tony's going to be helping, and Monica, you know, it's great to see new leadership in place and continuing what those before you put in place. So thank you.
Thank you. I also just want to add, this is the last meeting of the year. And I just wanted to say thank you for everybody for being part of it this year. There's been just an amazing amount of work. The lift that we've done this year was amazing, and you know, small feat. And I just want to acknowledge that everybody here really played a part in that. Acknowledging, you know, Tony, he stepped up in interim and has really helped in a lot of ways. And I think his commitment to transparency as well is very appreciated. And we look forward to seeing what 2026 brings. And I know and us with Monica also, I think that there's a lot of good things that are going to continue for us for 2026. We still have a lot of challenges. There's a lot going on in our community that we, you know, that's heartbreaking. And I don't want to make light of that. But I think everybody showing up here with a passion and commitment is something I'm really proud of. And to thank Jonathan, Sue, and Maria for leading us through the first term of this year. And then thank you to Kimberly and Sue for sticking with the executive officer role so we can continue to move forward. I appreciate that. And then I feel we're very fortunate because we do have longevity on this board, which is wonderful. There's historical perspectives that not every board has. And then also the infusion of new members. I think we're really lucky to have that perspective. And I think that really makes it unique for us. And I look forward to again seeing what we do. So thank you to everybody. And I look forward to 2026.
I just wanted to add, the other thing I'm thrilled about is the level of diversity that has grown on this board. It's so important because not everybody experiences mental health problems at the same level. And it's so important to have a good range of ages, a good range of ethnicities, both genders, and assuming there too, but whatever. Anyway, I'm absolutely thrilled, and it's so exciting to see all 15 of those names filled in and not vacant. It's headed in the right direction.
Thank you. Okay, with that, now we will open to member announcements.
Oh, that was a member announcement.
You can make it. It'll be it's a nickname.
You have one you want to make?
No.
Okay. I attended a addiction intervention court graduation last month. It was a couple. They had two small children, and they both were able to get through the program and graduate, which is really something that was really moving for me because I've seen couples where one makes it and one doesn't. One's out on the street, homeless. The other person has gotten through treatment, and they both graduated together, which it was really kind of heartwarming. And the HA staff who provides the services for that program were able to get them through that. It's a minimum 18-month program. They're still engaging, so it's a real positive. There is another graduation for anyone who wants to attend Friday, December 19th at Department 6 in the courthouse at 2 o'clock. They'll have some business will be going on. I'm not sure if they'll start right at 2 or be 2:30 or somewhere in that time range. If anyone's free, anyone's welcome to attend. It's open to the public. I'm also the veteran representative on board here. So last month I went and engaged the veteran service officer. In the process from when I first did it 20 years ago, as opposed to now, is very different. I just want to say that the staff was very helpful. I got a call back that same morning when I called. When I went in, they were able to set up a meeting for an assessment. I'm a disabled veteran with 10% disability for physical stuff. And so I went in and had some other stuff. And that was really quick, in a couple of weeks. And that happened, the assessment actually happened this week. So it was a very short time frame compared to 20 years ago where you're waiting 3 months to drive down to the VA hospital Martinez. This was in Sacramento. I did take some time to ask questions about engagement and services. There's an 800 number that veterans can call to get an appointment quickly for mental health or addiction services. One of the things I do want to get a presentation from the VSO. One of the gaps, when we do this now or the last agenda item? But I'd like to get a future presentation from the VSO, because I've seen with veterans who are criminal justice involved, who are seriously mentally ill, the VA doesn't provide case management services like we get for the full service partners. And there's a gap there. And I'd like to explore trying to fill that gap. I remember one individual that couldn't go into our mental health court program because he had VA services, he's 100% disabled, was not eligible for Medi-Cal, and to go into the mental health court program, there was a requirement for getting services through the county. Works better that way for mental health court just because of the way the staffing's done. And so that was one. There was one last year, combat veteran, 100% disabled with PTSD, living out of motels with his wife and family. And he didn't have a case manager to help with him getting more permanent housing. And he was someone that probably needed to go to the Menlo Park residential program there's a really good program there for PTSD. So there's a gap there. I just wanted some future meeting to get a kind of presentation on VA services. We haven't done anything like that since I've been on the board.
Okay.
Yeah, we'll work on that. That's a important gap that we need to better understand. So thank you, Chris.
Yeah, we had a former board member who was worked for the Department of Veterans Affairs in this particular area. It is a gap we have been able to figure out.
Well, and thank you for the update on the mental health court. And that's exciting that you have, that positive information to share, especially with a couple. And that's amazing. So thank you. We know it's amazing for men.
I have another member announcement. As many of you know, I graduated from UC Davis this past June. And while I was at Davis, I was on the NAMI at UC Davis chapter, and I was president for a while. But I am excited to introduce Rade. I think he might be online. He may have had class, he may have had to step away, but he is currently the president. He's been doing a fantastic job, and I wanted to just kind of make that connection known that we still do have that connection with Davis, and there are students that are listening and would love to see all this great stuff and progress that we make.
Yes, hi. I just wanted to, build off of that. My name is Rade. I'm currently, like Nithya said, the president here at UC Davis for NAMI. And I kind of liked what we've been saying and just, keep destigmatizing mental health and mental health problems, especially on a university campus. So I wanted to do a, personal shout out to Yolo County for doing YOLO walks, doing all of those things to, support that cause. So thank you so much. It's great. It's great to finally meet you guys. I know we're virtual. Hopefully I can see you all in person, but yeah, just thank you so much.
Thank you. We appreciate you having you here. And we're great that there's another person following in your footsteps. That's awesome.
Yeah.
Thank you. And let us know if at some point you want to provide a presentation to the board.
For sure. We'll put it together.
Great.
100%. Thank you.
Any other announcements? Okay, we're going to move on to the next section, so I'll open it back up to public comments. Join or anybody that
Daniel.
okay, great. There's no course. There was no correspondence. Sorry, Chris.
No.
So next up, we have public guardian. Lori Haas here to give a presentation around SB 43. We're so grateful to have you. Please, like her, Christina.
Let me just see who's not on mute here.
Rob Villarreal and I do this little presentation
That's
together.
right. Sorry, Rob, I didn't mean to.
We have our
I
little
knew
song
that.
and dance. We've been going around the county to introduce SB 43. Do you prefer that I brought a few slides? Do you prefer that I stand up there?
It's really up
back
to you
here?
and Christina how you want to run it.
Okay, I guess I'll stand up there so that you can also see the screen. And that way, if you have, I'm hearing impaired, so if you have questions, it'll be easier for me to hear. I'll follow.
Sounds good.
Let me
We always
pull
love when
these
you do
up
it.
real quick.
Pardon me, you always love to do those.
While she's calling up the slides, I just wanted to remind everybody, we have 2 community information sessions. The first one is tomorrow night. Rob and I will be hosting that. The second one is Monday night, both at 5:30. So we're really hoping that, community that may work during the day are available to join. And it'll be 2 hours. It'll be the same information from us both times, but there might be different questions from the community. So people are invited to join one or the other or both. I think you each have one of these. Also, I wanted to just do a quick update on what the county is doing right now for SB 43. The most recent update isn't in the behavioral health director's update. We are now meeting twice monthly. We're kind of in crunch time. It's a really great collaboration between behavioral health, public guardian, HHSA, fiscal and contracts, and really putting our heads together, communicating with other counties that have already gone live to determine how we can best prepare. And we are in Yolo County going live on January 1st. So it's right around the corner.
Let me check in with the online to see if they can see the slides because it looks different. I can't see them up here for some reason.
I can see them.
Okay, very good.
But they won't show for the group here.
They're not going to show up here, but they're showing online.
Okay.
We had to do a workaround, so it looks strange.
But the folks in this room won't be able to see.
Oh, let me see if I can figure that out.
Okay, or maybe the email I forwarded to you. Well, folks don't have their laptops. I know we only have 20
Let me
minutes,
just change
so-
my screen real quick.
Yes, thank you for bringing that. So we have 20 minutes. We have a tight agenda, but we can certainly bring Lori back if we find that we have a lot of questions or we have a lot of questions about a specific, and we can certainly bring you back virtually.
Okay.
We appreciate you in person, but.
So we'll just plow through our slides. I'm going to start us off and then turn it over to Rob, and then take up the end with some conservatorship information. So this is specific to Senate Bill 43. Next slide. There are multiple updates to the LPS Act that were initiated with SB 43, but the one that pertains to the community the most is the expanded definition of gravely disabled. So we have the old definition, which was pretty narrow, and the new definition. You can see where the updates are in red. So I won't read it exactly since everybody can see it on the old definition, but for the new definition, it now includes a condition in which a person, as a result of mental health disorder, a severe substance use disorder, or co-occurring mental health disorder and severe substance use disorder, is unable to provide for their basic personal needs for food, clothing, shelter, personal safety, or necessary medical care. So you can see it's expanded quite a bit. Hopefully this will enable us to assist more people. There are still, people still have rights. And so not everybody will meet criteria, but it at least allows us to attempt to assist more people that have substance use disorders. And as I said, we are implementing on January 1st. A couple of things we wanted to bring to your attention in that new definition. It refers to, sorry, next slide's okay. It refers to personal safety. So the Welfare and Institutions Code defines that, doesn't give us a whole lot of explanation, but defines it as the ability of one to survive safely in the community without involuntary detention or treatment pursuant to the LPS Act. So so that's what we keep in mind when we're considering the new definition of gravely disabled. It also talks about a person's ability to access their necessary medical care. They give us a pretty detailed description of that. And the key points from that is that this necessary medical care, if they don't access it, is going to result in serious deterioration, that it's likely to result in serious bodily injury, meaning injury involving extreme physical pain, substantial risk of death, or protracted loss or impairment of function of bodily member, organ, or mental faculty. So it helps us determine, if somebody's refusing their flu shot, they're obviously not going to meet criteria. But if they, for example, have, maybe they're an amputee and they're on the street and they're not able to care for that because of a mental health disorder or substance use disorder, and they're likely to die from infection from that, they may meet criteria and be gravely disabled. I'm going to turn it over to Rob at this point because there's also reference to severe SUD, which is very specific in the diagnostic and symptoms manual. And he's also going to talk about the 5150 and 5250 holds.
Okay, thank you, and thank you, everybody, for the opportunity to discuss this. So severe SUD, part of what we're looking at, part of what we're doing is working with law enforcement and a lot of the emergency providers to fully understand what we're looking at. When we're looking at severe SUD, we're looking at observable behaviors or symptoms that will substantiate the reason for those holds. Is somebody having increasing tolerance to alcohol? Is somebody having withdrawal? Personal safety, are they placing themselves in jeopardy by going out and doing that behavior, that personal safety issue, and then, related to their substance use? Aside from that, again, their behaviors are increasingly placing them in risky situations. And we probably are primarily looking at a couple of these observable behaviors right here. And again, the focus is to assure that just because somebody's intoxicated, somebody might be a little elevated on methamphetamines or whatever the case, there's a certain point in where that person is not making the safe calls for themselves. The whole purpose of one of the purposes for welfare institute code is for safety of the individual, safety of treatment in the community. And really that's that focus to make sure that those individuals that may have that severe SUD component are given that chance to go ahead and be evaluated, where in the past they were never given that chance. Again, part of that evaluation is the initial application out in the community or in the emergency room sometimes, to go ahead and look at that criteria, physically what's going on with those individuals. And part of that criteria also is a triage as to where their needs are. If somebody is severely impaired due to their substances, we're going to look at the medical component first. We're going to make sure they're doing okay. That's primary. Then we're going to go ahead and look at the substance use, because the substance use does affect the physical health. That's that triage process. And of course, the mental health is ultimately where we're focusing on. The whole person is what we're really looking at. And so when we're looking at this criteria, we're really looking at the history. We shall take into consideration their history and information from family or individuals involved. And then also tying these behaviors into their quality life or their impairment or inability to affect some of their life domains. Go ahead. So these things are we going to consider. And the 5150 is really based dangerous to others and greatly disabled. The probable cause, and that's one thing that as providers, we're looking at what is the probable cause. And for this, or before, it was just primarily mental health. But this now gives us the opportunity to reach out to those individuals that have not been or have been on the outskirts, not accessing those services, to expand that probable cause to include substance use. We're looking at a lot of individuals that metabolize, and when they're taken to the emergency room, metabolize, and they're assessed and they're released. But this criteria takes it a little bit more to where if those individuals, after they appear to be metabolizing, still have those challenges, then it's gonna be that determination of those individuals in the emergency room to continue that hold if necessary. Determination of those 911 calls, again, part of that whole triage is, I think we've had some individuals that have been with emergency services. Again, physical health. That's a thing. We're not going to delay services. If we're there and providing behavioral health services, we're not going to delay any physical health. We're going to make sure that's primary focus. The criteria really hasn't changed as far as the focus of gravely disabled as danger self, others, and gravely disabled. It's given us the opportunity to get a population that's been on the outskirts to really get them into services. Serious harm is understood as significant deterioration. When we're talking about somebody that may be going out and getting their, Lori was talking about those individuals that have chronic health issues. And part of the gravely disabled determination is their judgment impaired, placing their safety at risk. The health component comes in where, it is within the scope of that professional determined medical necessity. So while we're out in the field making that determination of personal safety and their judgments impaired, is that also placing their health at risk? We may go ahead and make that application to have that person evaluated in the emergency room where those professional staff within their scope of practice can make that better determination. So the impacts, well, in speaking with our partners at Sutter, Davis, Woodland Memorial, and some of the other outreaching agencies we work with, there has been an initial impact in increasing emergency room visits. The emergency rooms have been able to go ahead and address a lot of those issues and also help individuals navigate to outpatient services. But for those individuals that continue to need detox or whatever, we're arranging to have the navigators in the emergency room help those individuals access, whether it's outpatient or inpatient SUD services, whatever is most appropriate for them. And we also understand and reached out to many of the psychiatric facilities that are the LPS, that they have their processes that for detox evaluation and also have rehab components. So a lot of facilities will go ahead and make that transition from the initial 5150 detox and, if appropriate, to rehab or dual diagnosis programs. Let's see, I think the law enforcement, the component for law enforcement, we are going to be doing our continuous outreaching and to attend every briefing that we can to give them the information they need to make solid choices. With that, we also have 24-hour crisis response in which those officers know if they have any questions, they can go ahead and consult with us. With that I hope would address most of the impacts with law enforcement. But again, they have our numbers. If there's anything and they call often, we'll give them the support they need. As well as the outlying agencies, we've touched bases with UCD, Rory Grabo, Dr. Grabo, who's been our primary contact, and he is making sure that UCD is up to speed with the new criteria as well.
I think you have one more.
Oh, do I have one more? Patient strengthening connections right here. So part of that, I think, also as we're expanding these services, we're really going and making this connection with the SUD providers and really reinforcing, and they know themselves that this is coming. And Sacramento has been able to go ahead and develop some good protocol for transferring over to emergency room to patient providers. As well as that, we're also looking at additional options for individuals that are voluntarily wanting to help. We are developing receiving centers. We're entertaining, or should we say entertaining? We're having discussions with other facilities to go ahead, and if somebody is voluntarily wanting services, we will help them access that. It doesn't always have to be an involuntary hold. And that's, I think, part of what we're going to help them navigate.
Question. For that would include, I guess, going to Walter's house. the voluntary. For the wait list for Walter's House, there are certain categories that kind of go to the head of the line. Like what individuals.
Yeah, and I think Julie Freitas is working with and addressing those right there.
This category of potential clients kind of have that same going to the head of the line so they can be placed, because quite often there's a wait for placement and residential treatment.
Right, and that's part of where, some of that waiting is that we're looking at, one, co-occurring disorders. They may be a reason for them to go ahead and get support over at Safe Harbor temporarily. Okay, and so they will have enough time to go ahead and hopefully develop a more cohesive plan with treatment providers. And then also some of the crisis receiving centers will go ahead and help those individuals coordinate care. And it's really looking at that, not just this is a Medi-Cal population, but everybody in the community is what they're going to look at and focus and get the help.
Does that answer your question? I'm curious, because sometimes there can be months long.
Oh, yeah, no, I
for
know.
residential bed, so.
But
it can be
Walter's House is
expensive.
Walter's House is not the only program. I mean, we have Granite Wellness, and then, depending on those individuals, if the beds are not readily available, we can engage them into wraparound services until they do that. So it's not that our focus is not to let anybody slip through the cracks. Sadly, sometimes that happens. We're going to do our best.
I hate to ask this because it sounds too good to be true. And so I'm wondering if this is an unfunded mandate or if there is, in fact.
We have a winner. Yeah, so I mean, there are definitely elements of this that are unfunded, and it's been flagged, and there's language in the bill itself that says something to the effect of the State Department of Mandated Services determines that the counties are incurring a cost because of this if they'll develop something, right? But there's
the checks in the mail.
Right, so I mean, I think part of what the work that Rob and Lori are doing right now is making sure that the community is aware of it, right? But as with the community awareness is spreading, and with advisory bodies like this and advocacy groups, like we also want to make sure people do know that there are definitely elements of this that are not funded. And so, for example, on the behavioral health side, there's a lot of this that is just kind of in our wheelhouse anyways, right? But on the public guardian side, this is potentially a workload increase, right? And public guardian is essentially fully funded by general fund, right? And so, there is a kind of a sticking point right there, right? And we're trying to estimate, we're trying to get an idea of how to estimate what it might look like. But I think that it's impossible for us to know until we actually get going, right? Every community is a little different. We've been doing a lot of crosswalking and comparing ourselves to San Luis Obispo. Maybe we should consider Santa Cruz as well, right? But San Luis Obispo is similar in size to Yolo County. They implemented back in 2024,
They
right?
implemented in
Right,
2024.
day one. And so we're able to look at them and see, okay, what's happened, and what some of the data that's come back already was like 50% of the holds really didn't meet criteria, right? And that basically over the course of the past couple of years, it's all of the work that they've done has only resulted in one LPS conservatorship, right? So there's some additional costs that are going to be associated with it that way. But the part that is hard for us to kind of estimate and hard to know is like how much time is being spent, right? Even on all those other cases where they didn't result in LPS conservatorships. So I think the answer is kind of like yes and no, right? It is an unfunded mandate, but there are elements of it that fall within the things we're supposed to do anyways.
If I could add to that just a little bit too, I think another challenge is the whole concept of how do you enforce SUD treatment. Someone has to want to improve. There's very little that can be done involuntarily, and so there's definitely some challenges with that. The way I've been looking at it, because we have to do this, and it's another opportunity to try to help people. So the way I'm looking at it in that regard is we get an opportunity to offer things to someone who may come through with an SUD only diagnosis or co-occurring mental health disorder and SUD. We get that opportunity. We do our best to try, whether it's through behavioral health or if that isn't working through LPS conservatorship, we get our best to offer these services. We get that opportunity, we do our best, and if we can't get them that time, maybe the next time, and we just keep trying until hopefully we see improvement. And and I hope that it will help get more people on the right track than we could currently under the old diagnosis. But you're right, it is a little bit too good to be true. It's not going to help everybody. There's definitely barriers with it.
Question. So I'm glad you're speaking with UC Davis.
Pardon?
I'm glad you're including UC Davis in this conversation, even though they're Sac County. A lot of our residents end up over there, especially in trauma, right? So when you're speaking with hospitals, I guess part of what we hear from the community over and over from families of loved ones is they fall through the cracks and they're very frustrated and they're discharged out of ERs or hospitals, and the hospital cannot make them take their medication. So they're discharged with even less insight than they may have had before. And they're competent to make a poor decision, kind of is how it's framed, right? And so I'm not debating that. I just am curious how this bill might help families with that. And I think it's great you're doing the education sessions, but I mean, we do know that we have families falling through the cracks. And so, what would be is this maybe potential?
So we actually, we've been meeting twice a month, and we actually just talked about this a little bit at our meeting earlier today. And please jump in, this is more in your wheelhouse than mine, but we were talking a little bit about, what does that look like when ERs are breaking holds, or, how do we get, we've done 2 sessions similar to the ones coming up for the community. We've done 2 last month for hospitals and law enforcement. So we're hoping to get information about this out to them, but I know that we talked about what are some other ways we can help educate them on this new expanded definition and help with that navigation. Even if they can't necessarily make somebody inpatient, what can they do to navigate that person to the resources to try to improve their circumstance?
Yeah, and part of that education also is to get the family to understand their civil rights. And there is a process. And unfortunately, sometimes individuals have to cycle through and hopefully not fall through the cracks, but our eyes keep on them to make sure that if there's an opportunity to help them out, we do.
Oh, I just was going to ask a question. I know that there was previous legislation where you could submit information from family members to be considered.
The codes say that you shall take into consideration information from family or significant or the treating practitioners. And additionally, you shall take into consideration history of the individual.
Right. So I just know that personally that helped my family like 10 years ago when in Alameda County they had liaison that would walk you through what to present. So when my brother was being evaluated, we brought photos and history and he was finally hospitalized and it made a significant impact. So, and I didn't know any of that information until I called advocates in Alameda County. So I wonder about families not understanding that.
We do our best to educate.
Oh, I'm not saying.
No,
I mean,
when we're on scene, so they
Yeah.
actually have some, when they're on scene, sometimes they have no hope. And so if we provide them some guidance, direction, some understanding of the process, then they can take a little bit more active process in helping their family out.
Yeah, for sure. Okay.
Some around the table maybe have called me in the past and heard my whole spiel about, when they're wanting to know, how, this my loved one has had all of these 5150s and 5250s, but they just keep getting released. They need to be conserved, but they have to be referred by a hospital. So one of the things we're trying to educate families about is, keep track of all those things you know about between the hospitalizations, get them down in writing, get them to the hospital the next time they're on 5150. The hospital won't be able to talk to you about what's happening unless your loved one has given them permission. But they'll receive information from you, especially if you have it in writing and say, here, just take this. They can't tell you whether the person's even there but you usually know.
Yeah.
And so if you just give them that information, they're gonna be interested in that history.
Yeah,
And
that's
it's,
great.
and it's so important, like you said, photographs
Yeah.
of their living conditions and everything change because the providers aren't out in the field.
Right.
They're only told what they're told by the client.
Yeah, and it's
And so the
self-report,
pictures,
so then
yeah.
it's just the cycle that happens, yeah. Thank you very much for everything you do.
I just wanted a clarification. When you listed the criteria for substance use disorder, it doesn't say anything about the actual substances, just the way that they're using them. Is the law really written that broadly?
Yep, well, the law just says severe substance use disorder or chronic alcoholism. It doesn't specify, we've had that question come up a few times. It does not specify the type of substance. And then what showed the criteria were actually from the DSM, the list
What they
of the 11 criteria. In order for it to be a severe SUD, 6 of those criteria have to be met.
Right, any substance at all? Okay.
Yeah, I mean, it's a little hard for me to picture maybe somebody who's misusing
Yeah, not
marijuana as opposed to
like-
maybe fentanyl but yeah,
Yeah, okay.
the law doesn't actually specify, so,
Okay,
yeah.
thank you.
Yeah, we've been talking about that. Somebody else.
I
had a
just wanted to
question.
make a statement.
I had a couple of specific questions, especially about the process. So I think we're all fairly familiar with how the hold process goes for regular like psychiatric holds. So police or the co-responder write the hold, they take them to the ED, and then ambulance transports them to psychiatric hospital, wherever bed's available. That's what I think as a board we're familiar with. Can you walk me through how it would work for substance use? So if the person is put on a hold out in the community, who's writing the hold? Where are they taken? And from the ED or whatever receiving center that they're at temporarily, if they need to be on a longer hold, where do they get sent?
Thank you for that complicated question there, so I'll go ahead and get that to you. So the process is getting them into the emergency room based on that criteria and the expanded criteria. Once they're reevaluated and determined to still meet that criteria, they'll be referred to whatever licensed psychiatric facility is able to go ahead and receive them. Psychiatric facilities review the referral packets and determine their capacity to manage those detoxes. And so based on their capacity in that individual's presentation, they're being on the 5150, it will be the regular 5150 admission, but also with a detox protocol. So they will identify, look, this is somebody that's on, we'll say an SB 43 hold, we'll just call it that. They will go ahead and look at the referral packet, determine that this person has a chronic use, and they already have, because I worked in a psychiatric facility, we have preset detox protocol. And so when we identify those as individuals that come into the unit, they're asked lots of questions. They don't get to sleep for a while, but they get these questions, and they're going to have a cursory physical. And then they're going to determine again what degree of detox, if indicated, they will have. And then as they transition and they're through that detox, again, detox can be 3 days with alcohol or 20 days with benzos. So it really depends on the severity of their addiction. They can go on a 5250. They could go on that 5270 because that's sticking with the grade disability component.
As long as they're in the ER.
Well, no, when they get transferred to the emergency room. So they're on the 5150 in the ER. They go through the threshold at the psych facility, and it will follow that same process with the 52 and
So the conundrum becomes when people get admitted, right? And so,
or when it comes to the LPS.
right, and so maybe that could be something maybe we could talk about next time is, people who have a medical condition who then get admitted because they need to be medically cleared, they get admitted, and now it's a little bit of a different issue, and I hear from families that's another place where we're seeing gaps, and so I think that's a complexity we won't probably have time to address tonight, but I would be curious, as you start talking with our partners out there, how are they going to partner with you to address the people who actually get admitted into an acute care facility, right? Because they're not now. Right, so, yeah.
Yeah, something like, I guess like a concern I've heard previously about SB 43 is it's putting more people into a system that is not equipped to handle substance use specifically. So psychiatric facilities. I used to work in EMS, so anecdotally, I've seen a lot of people go into psychiatric facilities, and I kind of know, like a little bit of personal experience. I kind of know what's in there, and essentially, a lot of these facilities are not built to address substance use.
Not straight SUV, no.
Yeah. So then, as in, there's often people with co-occurring disorders that come in, but then a lot of these facilities, they're not geared towards substance use specifically. So essentially, from what I understand of current private hospital systems, there aren't locked facilities that can really, or there aren't locked facilities that are geared specifically only towards substance use.
Yeah, correct.
There's not enough of them compared to how many hospitals and beds that there are available for psychiatric services. So I was just kind of wondering what's that going to look like on the hospitals, and I know that's not kind of your scope, but I think it's good to understand where people are getting sent. Because I think a concern with SB 43 is this just going to create a revolving door? You put someone on a hold, if they don't get the appropriate treatment, then they're just going to come right back. And what was the point of the legislation if people aren't getting proper treatment? Because it's not just getting people into treatment, it's getting people into correct, effective treatment.
So I think that you articulately spelled out the complexities of the legislation that were driving the decision by many counties to delay implementation, right? And I will be perfectly honest with you when I say that the 2 years hasn't clarified the issue. Like it wasn't like these facilities sort of just sprang up overnight. Now we are familiar, we are aware of a specific facility in the Sacramento area that can provide that. It's I don't want to say prohibitively expensive, but it's expensive, right? And so really the entire conversation in terms of kind of what you're saying with families who are reporting that they're already falling through the cracks, right, of an existing system that isn't necessarily equipped to deal with all of these needs, right? That somehow or another that this legislation is going to create an environment to provide a more expensive intervention, and that somehow that's going to come about seamlessly, right? And so that, I mean, that's the reality of the conversation, right? In theory, yeah, it would make total sense, right? You know, someone meets this definition and we get them to the appropriate facility where they need to go. That's the long-term vision, right? And so, you know, for us with our local implementation, it's really about us as an internal system from the County Health and Human Services Agency, be working hand in hand with Public Guardian and Behavioral Health, working with our partners. And, you know, I don't want to say it's like a trial by fire or something like that, but I think it's going to be one of these things that we're learning as we go. And we're trying to anticipate what we're going to need. The problem is it's hard to know exactly how much demand there is going to be, even though anecdotally, I've heard that people have been waiting for 2 years, right? And that we know that there is likely to be some demand on January 1. You know, the other part that is relevant is some of the other elements that you're talking about, right? We don't know how the hospitals are going to respond. We don't know if people are going to be released from holds. Also the legal system, right? And individual legislative efforts, individual initiatives like this that involve a legal component play out differently in different counties. So the CARE Act's a good example, right? And you know, with one county to the next, the different way that the community interprets the legislation and that the judges, you know, that determine how the legislation should work. And not to go too far off topic, right? But you know, some judges with the CARE Act are like, this person does not want to participate, so I'm closing the case. Or in other communities, it's like, we're going to keep this open. Right, we're going to keep trying to make this work, right? And so, not, you know, again, it'll depend, like, to the point that Lori was making earlier about how are we defining substances, right? How are we defining severe substance use? And it's a civil liberties issue, and we don't know how our local judges are going to respond to some of this until we get there. So.
think it would be great if we could maybe come, maybe in 6 months or 3 months after you've kind of seen, like we've had a sense of
100%.
what's
Yeah.
happening.
Yeah.
And
Once
maybe
we
give us,
know.
once you kind of know, because now we know there's a need, but we're not sure how it's going to pan out. We're not sure how things are going to be interpreted. So it would be wonderful if we could slate
100%.
your team to come back and kind of give us an update. And then maybe that might also.
I think more than anything else, we want you to know that we know we have a responsibility to do this on January 1, and we're ready to meet responsibilities, right? Just, again, in full transparency, there's a bit of it, like we're preparing we're being as prepared as we can be, right? And we're happy to come back and give you an update after we implement.
Kind of
And we're
figure out
having-
a lot of what ifs, a lot of what ifs. And so
We're having a lot of discussion about exactly what you brought up, about what does this look like, specifically about the issue of somebody whose diagnosis is SUD only, because there are no SUD only involuntary facilities. They don't exist in California.
Yeah.
We are feeling a little more optimistic about people with co-occurring disorders because, we already see that for people who reach the threshold needed for LPS conservatorship. And what we're discovering is that many of the facilities that we're already using may have had, some SUD programs, some classes offered, but they're now beefing that up because several counties have already gone live with SB 43. So we're more hopeful about that. But there's definitely challenges associated with, how do we make this happen? I think it's a big impact on the ERs and, and figuring out where those placements will be. I think at this point, it's offering for somebody who's SUD only, offering them the services until finally they connect and are willing to access that.
Well, do we plan to pick up more beds to accommodate SB 43 next year? That's a question. And then a comment that I wanted to make was like families like mine, our kids keep going through these processes, dozens of hospitalizations, conservatorships with anosognosia. They don't know they're ill and they fall right back into the same dual diagnosis patterns. So just keep in mind that we're looking at SB 43 as a lifeline for our kids, It may or may not play out to help us that way because Care Court has been a disappointment for many of us, but there are a lot of mothers, families here in Yolo County who are experiencing what I'm going through as a parent. So I would hope that we can funnel some of them into LPSs. I guess that's what I'm hoping for. I really am a firm believer at this point in time with my experience that involuntary treatment is kind of the only path for some.
And I think, one of your first question was, are we looking at purchasing more beds? And so there's a couple of challenges there. I think one of the messages we want to share is, although this gives us new opportunities to help people, we also have to manage our expectations a little bit because of the challenges of no funding. I believe we're already over budget for our number of beds we have for our current LPS conservatees. And, we have the facilities are stepping up to provide what's needed for people with dual diagnosis, but with co-occurring disorders. But there's no funding there for counties to then, or at least for Yolo County, to purchase more beds. And there's always been an issue with all the counties in California are competing for the same beds. These facilities for LPS conservatees are private facilities. They can sort of cherry pick who they're going to take. And you can't just purchase a certain number of beds there if you don't have your own facility, which Yolo County does not. So definitely challenges. I always keep you specifically, Melanie, at the forefront of my mind, just because of all of our conversations and thinking, all of these things we're trying to put together and managing expectations, but people like Melanie and family and others, they're people, they're real people who are experiencing this, and us saying there's no money, there's no placement is not good enough. So we've got to come up with a way to make this work the best way we can.
So what I would say is the short answer is yes, right? The shorter answer is yes, is we intend to identify a mechanism to provide more beds. The more nuanced answer is that there's a cost benefit trade-off somewhere, right? I mean, so really what is happening as we're going into the next budget cycle is we have to start identifying what our priorities, right? And we'll talk a little bit about that in terms of the MHSA plan update that we have to talk about, and as we're going into the BHSA plan update, and really around how, with limited funding, right? How do we prioritize what the community is telling us is important, right? Because we're in a current fiscal situation where there is just not a way to fund everything, right? So this is definitely one of the areas that we've known is a priority. Like we've been looking at January 1, 2026 for a couple of years now, right? But it's then something has to give somewhere else, right? So, but the answer is yes.
Okay, and I just wondered if, this may be a silly question, but like if they have Medi-Cal and all that, does that all come into play in terms of accessibility and having more dollars? Like if we do enroll more, if we enroll more people into Medi-Cal, if they're qualified for Medi-Cal and Medicare, I mean, can that offset so that it can create more pathway?
It doesn't impact Public Guardian at all.
Okay.
We because we aren't a service provider, we can't bill Medi-Cal for anything. It might maybe.
When we have a little bit more time, we can talk about the impacts of HR 1 and how that's impacting Medi-Cal enrollment as well. But yeah, I mean,
But in theory, it does. It's
Yeah.
supposed to. It's not gonna cover every service. That's what we're gonna learn. But it should cover some of it.
To do that.
Yeah, thank you.
Will we be able to get numbers on the referrals? The holes that are placed, the old standard was, kind of pure mental health. We're gonna have a co-occurring disorder, a pure SUD, to see kind of what the numbers are coming in, or what the expansion is in the new definition.
That would be a behavioral health question.
I can answer part of that.
We want to do that, right? I mean, I think that part of the I don't want to say the challenge, right? Part of the responsibility for us is like developing like a data collecting mechanism that can adequately sift that out, right? But yeah, that we as a county, we also want to find ways to track our time and because we've already invested quite a bit of staff time into preparing for this as well, right? So I mean, we have a lot of motivation to get the kind of data that you're talking about, in part just because we want to know, right? But also because it's an unfunded mandate, and it would make a lot of sense for us to keep track of our costs in the event that the state ever does choose to find a way to reimburse us.
If we could, our board, make recommendations to the board supervisor. You're looking at unfunded mandate for care court and this unfunded mandate. Both are incurring costs for the county. Is one more effective than the other as far as getting people into treatment? And therefore, maybe that's a place where the funding should be funneled as opposed to both.
Yeah, I think that's a great question. And so I'm not trying to be a discussions changer here, but we have, Tony has offered, he's got basically the MHSA budget boot camp, which I think will help us as a group. I think that's a very important question. Melanie, you have a question. So I've given Lori 5 extra minutes. We're already over. And then maybe if Tony wants to answer that, he might answer it in his presentation. If not, he'll answer it. Just so we can.
I don't think we're going to answer today.
Right, but I mean, I think he's got a list. He's got a.
He's checking twice.
He's checking twice. Yeah. So I just want to make sure we have time to get into the budget piece because we all have, we need to know that.
Okay, so with my 5 minutes, I'm going to try to just slam through these last few slides that are specifically to answer questions or describe what goes on with the LPS conservatorship. So, the LPS Act encompasses all of the involuntary psychiatric holds. We tend to refer to LPS as just meaning the conservatorship, but it's actually only a piece of it. So the new definition definitely does apply to LPS conservatorship. Person has to be gravely disabled under this new definition. I also just want to point out the process for referring for LPS conservatorship has not changed. And I have a slide that addresses that. Next slide. So to qualify for LPS conservatorship, it's an extremely high threshold because a person loses significant civil rights when they are placed. It's basically, it's like a 5150, but it's for an entire year. And so that's why the threshold is so high. So they need to be a county resident. They need to have the mental health disorder or substance use disorder or co-occurring mental health disorder and substance use disorder. They need to, that disorder or disorders results in them rendering the person gravely disabled. So having those diagnoses alone is not enough. It has to also render them gravely disabled under the definition we talked about earlier. There has to be no less restrictive or no other suitable alternatives that are available because LPS conservatorship is the absolute highest, most restrictive level of care. And the proposed conservatee must be gravely disabled and unwilling and or unable to accept treatment voluntarily. That part of the code has not changed. And so just really quickly as a reminder, the current process, and it remains this process, is that those referrals come to us from the hospital that's treating them. The purpose of that is that a person has a right to be held on the shorter involuntary holds first to see if they can gain insight, stabilize psychiatrically or detox, whatever their diagnosis is before they're tried on the longer, most restrictive 1-year hold. So that's why those referrals only come to us from hospitals after they've made attempts to stabilize the person on the shorter holds. Next slide. We're almost there, aren't we?
You're all good. You're good.
So these are some examples of suitable alternatives. We get asked this a lot, and the code, the Welfare and Institutions Code 5350 and sequence is what dictates how LPS conservatorship operates. And one of the codes specifically now says that a conservatorship shall not be established if there are less restrictive levels of care, such as, and it specifically names AOT and care court. And then some other suitable alternatives that might be considered, that, if a person either has been tried at these levels of care or supports and it hasn't worked out, or they're refusing to accept them voluntarily. So it might be full service partnership, wraparound services, it might be mental health diversion, it might be third-party assistance, which is support from willing friends, family, or other individuals. Next slide. So I think this might be my last slide. So this is, I wanted to specifically get to this because one of the things you brought up, Melanie, I wanted to address, which is, it's frustrating for families. Somebody you care about and love gets put on a hold, gets released, or maybe even gets on conservatorship and then gets off conservatorship and then they're back, in the same circumstance they were before. So I wanted to address that. So some things we have to be mindful of and that are barriers for LPS conservatorship is what we just talked about. There are less restrictive alternatives have to be tried or at least offered. And if they're refusing them, we need to know about that. The personal safety and necessary medical care that we talked about being part of the new criteria, it has to be significant and severe enough to cause serious bodily injury or death and must be related to their mental illness or substance use disorder. Third-party assistance. So this is when a conservatee says, well, I'm able to go live with my dad and he's willing to take care of me. We have to look at that. The law action, now we can find that would not be sufficient, but we have to at least look at that. And if it could work and it hasn't been tried yet, the law specifically says that if somebody can survive safely with that support, they are not gravely disabled. This is a big one, the highest burden standard of proof. So when somebody is put on a hold, there just needs to be on a 5150, there just needs to be probable cause. When we petition for an LPS conservatorship, we actually have to go present that case to a judge. If the conservatee contests, which they have a right to do, we have to go before a judge or a jury. The conservatee gets to decide. They can have a jury of 12 or they can have a bench trial with the judge. And we have to prove our case. They don't have to prove that they don't need conservatorship. We have to prove that they do. So it's our burden of proof. And we have to prove it to the highest standard, which is beyond a reasonable doubt, because that's the same standard as a criminal trial because they're losing their freedom. The only way we can enforce the treatment is for somebody to go into a locked facility. They're losing their freedom. That's why it's such a big deal and why we have to prove it beyond a reasonable doubt. The severe SUD diagnosis, we talked about that. We have to look at whether those 5 criteria have been met. We don't diagnose. That all comes to us as information from the treating physician. And then the last point, which is the LPS conservatorship lasts for a full year. And we have to reprove our case. If that person has improved and is now showing insight, first of all, during that 1 year, we have to step them down. We're actually mandated by law to step them down to a lesser level of care if they're ready for that. And if they've stepped down, and our goal is to step them down before that year. Our goal is that 1 year we get them back on their feet and we step away so their rights aren't revoked for too long a period. If they are showing good insight and they're at a lower level of care, we can't meet our burden of proof. And at the end of that year, we have to reprove, and it's still the highest burden and standard of proof. So that's why people get off of conservatorship. And our hope is that we always collaborate with behavioral health. We always make sure they've got their safety net around them. And our hope is that they'll do well and they will never need us again at the public guardian's office. But it doesn't always work out that way. So we're there if they come back. And that was hopefully my 5 minutes. But we can definitely come back.
I think we have a lot of questions. I think Tony's he's got a list, and we review these every month and kind of figure out our agenda. So we'll make sure. And then maybe you can let Tony know when 6 months, what makes sense for you to come back to kind of do an update of where you are, what you're experiencing, what we're experiencing as a county. But then I think there's other questions that we'll certainly probably Tony can address next month in another way.
Yeah, I mean, we'll come back at the board's request, but my best guess is 6 months.
Right. But then, the question that Chris had, there's things that we can address before. Yeah.
Yeah, that's fine. Yeah, I mean, we're happy to come back and talk about any topic you want us to talk about.
Yeah. Thank you.
Thank you.
Thank you very much. Thank you.
Thank you so much.
Appreciate you.
Thank you.
And if you really want to delve in and hear what the community wonders about it too, right there, either tomorrow night or Monday.
Thank you.
Apologies, I have to pick up my daughter.
All right.
I have a question before they go. Where is UC Davis for implementing crisis now?
What about the university?
Yes, the university, you mentioned before you've had conversations with the university on implementation of SB, but where is the university with implementing crisis now?
So I don't know if it's on the board's agenda and if I should or should not comment on it. What I can tell you is that at the board meeting, at the Board of Supervisors meeting next Tuesday, I will be talking about the county's implementation of the behavioral health receiving center that we're proposing to, we're asking for. And so I think that might answer your question then.
Yeah.
Sorry, Kimberly. We can also talk afterwards if you want.
Yeah.
My guess, however, is that when they were referring to UC Davis, they were talking about the hospital.
Correct. They were talking about,
Yeah.
they were talking about
Okay.
UC Davis.
I thought, I think they were saying SB 43 in the camp. I thought they meant the campus.
No.
Okay.
But I just want to make sure we know we have a public hearing. Basically, we got to get to this agenda, guys.
Okay.
So I just want to be clear. This is all great, but we also have a responsibility. So before though, Tony, you're going to go to public comment.
Go ahead.
So, okay. If anybody has a comment, especially.
I don't see anyone.
Okay, great, awesome. All right, Tony, it's all yours.
Okay, so you're in luck. We have a short presentation, right? What we're gonna be basically providing. Huh?
It's approved. We don't know.
Yeah, that's
You
right.
think.
we'll be providing the same presentation, maybe less eloquently and glamorously than I'm about to do, but next Tuesday at the Board of Supervisors meeting. So this is the MHSA annual plan update for fiscal year 25-26. As you all may remember, Mental Health Services Acts are funded by Prop 63 funds, 1% tax on millionaires. I think you guys have all heard this spiel here quite a few times, but just for individuals maybe who have not heard it yet. Prop 63 uses 1% tax on millionaires, right, to fund services that are distributed to the counties. We'll go to the next slide. As you can see here, the statute defines how the funds are to be distributed, right? So when Yolo County receives the funds, we are supposed to spend 76% of the funds that we receive on community services and support, 19% on prevention and early intervention. And within those categories, there's some specific requirements about spending 51% on FSP in community services and supports, and 25% on youth under the age of 25 in prevention and early intervention. We can also fund workforce education and training activities and capital facilities and technology activities, but those are transfers from the CSS category for when we do have those kinds of expenses. There's also a 5% innovations fund, which we talked about earlier in the year, where we had made a proposal to piggyback off of CalMesa's Smart Care electronic health record platform, and that's been approved by the board. Kind of in a little bit of a limbo with that right now, and that's basically how the funds are split up. We can go to the next slide. The piece that's relevant with this year's plan is that it's the last year of the Mental Health Services Act. As you all remember, Proposition 1 created the Behavioral Health Services Act, which we will be implementing in fiscal year 26-27. So essentially, the BHSA and the MHSA both involve like a 3-year planning process, right? So what we're going to be doing with the BHSA is planning for the next 3 years, right? This is an annual plan update for the final year of the approved 3-year plan. So fiscal year 25-26 is the 3rd year. The process requires a draft plan to be developed through a community planning process, a 30-day public comment period. We have to have a public hearing with the local mental health board, right? And a summary and analysis of the recommendations that are made, and a description of any substantive changes made to the proposed 3-year program and expenditure plan or annual plan that was circulated. Then the Board of Supervisors has to approve the plan, and the final plan is sent to the State and Commission for Behavioral Health. It is undeniable to say that we are way behind schedule, right? This plan was supposed to be approved by June 30th. And as you know, there are Christmas lights hanging. So we're now, for those of you who have been attending the board meetings all year long, you know the reason why we're so far behind schedule. We had a pretty significant change in leadership that happened in the first part of the year in January, when former Behavioral Health Director Colleen Chakowski left to CalMesa, and then we had our agency director who left, and so there's a few of those kind of things that were causing the new interim behavioral health director to need to get up to speed, and he did a great job. But the more critical challenge was discovering that we had an $11 million structural deficit, right? And that required us to kind of go back and forth with the board quite a bit in terms of how we were going to resolve that. So next slide, please. So this is a timeline of events for those of you keeping score at home. We did do a needs assessment community survey, listening sessions, and key informant interviews back in February and March. We did go to the board to say, hey, we don't think we have enough money in June and October. But we were able to finally get our budget approved in October, and we were able to post the plan for public comment on October 31st. The 30-day public comment period ended on November 29th, and today is December 3rd. We're having the public hearing. The plan is for us to have the public hearing, receive feedback from the public and from the board, and to package that feedback up into our final plan that we will present to the board next Tuesday, to the Yolo County Board of Supervisors next Tuesday. Next slide, please. So in terms of community feedback, this was from the actual community planning process. This was not from the 30-day public comment period. This from the initial community planning process. The key informant interviews had identified three key strengths: collaboration, dedication of county staff, and children's behavioral health. There were some system needs that were identified that included support for system navigation, increased funding, workforce stability, and expanded substance use services. There were specific programs that were recognized as being particularly impactful, including the K-12 School Partnership, crisis response initiatives, and mental health courts. And there were opportunities for growth that were identified in non-emergency behavioral health services and services for the unhoused who do not currently meet community demand. In the listening sessions, participants had identified 5 major concerns to behavioral health: funding cuts, homelessness, the need for frontline services, substance use, and the political climate. The perception of service availability was, as you, some of you had identified tonight, long wait lines, difficulty accessing services across geographic areas, transportation barriers, and staff turnover. And the participants also recommended increasing cultural competence efforts by improving the quality of translation and expanding on cultural competence trainings. And there were fund allocation recommendations to prioritize MHSA and future BHSA spending in terms of broadening data collection efforts, maintaining or increasing funding for existing programs such as crisis intervention training, crisis intervention services, mental health court, and PEI initiatives, bringing back the CREO program, housing, residential beds, and safe zones for the unhoused. So with integrating the feedback that we received from the community, we identified the following priorities that this plan is seeking to address. And this also includes feedback that we received from the board around what we should be prioritizing in our several sessions with presenting to the board about the budget issue. So the key priorities that are included in this annual update are focusing funding on mandated services, prioritizing services for Medi-Cal beneficiaries, maximizing reimbursement from Medi-Cal, reducing spending on discretionary programs, and measuring program impact on health outcomes. Next slide, please.
Too far.
These were prioritized programs in the annual update, and this is because this had a lot to do with our budget conversations. And I won't read off all of the programs here, but most of the programs that you see over here in the community services and supports are internal HHSA programs. In the prevention and early intervention area, there were the early childhood access and linkage program, college partnerships program, K-12 school partnerships program, parent family led support services, and this mental health crisis and crisis intervention is actually an internal program. What I will say is that in terms of the budget, I think that all of you have heard me talk about that a lot this year, so we don't need to belabor the point. But in terms of these contracted services in the prevention and early intervention area, those contractors took a 25% budget cut. So the early child access and linkage program, college partnership, K-12 school partnership program, and parent family led support services all took a 25% cut. And the remainder of the cuts that needed to be made, that still do need to be made, are going to be applied to internal programs. And these are the programs that will be affected. Next slide, please. Some of the highlights, the full service partnership program, as you may remember, our contractor did not choose to extend their contract with us. And so the full service partnership program for adults and older adults moved to an internal program on July 1. The program's former capacity was over 200 clients, and it's been reduced to 100 clients. I think we've talked quite a bit about that here as well, where we have been trying to serve more than 100 clients at an FSP level, and we're at a breaking point, right? And honestly, we're going to blow through our budget if we're not careful as well, right? And so we're actively working over the past few weeks to get down to the 100 identified FSP clients. The mental health crisis services and crisis intervention team, which have really been identified as one of the strong points of the local behavioral health system, responded to 1,165 crisis calls that resulted in 220 individuals being placed on a 5150 hold, right? What I will note here is how many calls did not result in a 5150 hold, right? And I think that's the more relevant data point, that the overwhelming majority of the crisis calls that we respond to don't result in a 5150 hold. The K-12 school partnerships was also identified as a particularly strong program, and they served an average of 633 students each quarter in fiscal year 24-25. Help Me Grow served an average of 1,500 children approximately biannually. So that means every 6 months they were serving approximately 1,500 children. And the Peer and Family-Led Supports program held 28 outreach events with 1,706 total participants. Again, I want to comment on the fact that all of those programs will experience a budget reduction in this fiscal year. One of the other pieces that has come up is that in order to make the necessary cuts to the budget for internal programming, one of the areas that we have identified as an area for potential cost savings is to close the drop-in navigation centers in Davis and West Sacramento. And so that was part of the original plan. When we had the last board meeting, the board members were understandably concerned about this approach, and had requested some data on utilization, because essentially we're at a place where we can really only afford to operate one clinic and not three. We'd already been experiencing some budget concerns in the prior fiscal year, which led to a reduction in the days that the Davis and West Sacramento clinics were open. And now we're at a point where we will need to scale all the way down to just one clinic. What this data set shows is that the overwhelming majority of clients that are, well, maybe overwhelming is exaggerating a bit much, but it's clearly more of the clients are being served in Woodland than the other locations. And so our recommendation, because Woodland is our main campus, is that would be the clinic that would remain open. Next slide, please. There is also some understandable concern from local stakeholders about what will happen to some of the programs that have really been identified as bright spots. So like the K-12 school partnership, Help Me Grow, right? Those types of programs. And what we are proposing is a plan to try to work with existing with providers who are currently being funded by MHSA, as we make this transition from MHSA to BHSA. So part of the concern is that some of the current programming may not meet the definition of BHSA in serving these identified priority populations. And so what we're proposing to do is to meet with the MHSA vendors in January, and to discuss priorities that are going to be identified in our community planning process. So we're in that process right now. We've already been doing the community planning process for BHSA. We want to meet with the providers, say, this is what we're hearing from the community about what our priorities ought to be. We're going to ask them to provide proposals about how they may modify the scope of the work that they're doing now to serve the HSA populations that align with those priorities. And then we'll incorporate that information, and we'll have to make some decisions about what to fund or not fund. But that information would be drafted into the BHSA integrated plan that includes approving that could include approving some of those programs, and then the rest of the timeline here is around amending contracts if they're approved and releasing an RFP. The idea really is this. Ideally, what we would do is release an RFP and say, this is what we need, right? This is what the community planning process is identified. We want to give everybody an equal opportunity to apply, and then that's how we would fulfill those services. We're not going to get to that. I mean, we're just not going to be able to do that. The county's processes are too slow, right? I mean, we would, if we release the RFP today, we might not be where we need to be on July 1, right? So the idea really is to work with our existing providers, right, to see if we can continue to work with them through the first year, right? And then try to put out an RFP for the second and third years of the plan, if that makes sense. Okay, next slide, please. That's it. Okay, so I know that was sort of the lightning round, but the idea here really is to get public comment and to get the board's feedback on the proposed plan. And I'm going to hand it back over to you, Meg, about how you want to proceed with the public hearing section of this.
I think the board has some questions.
Sorry, I've already got a question. Well, actually, two questions. First of all, are you going to send us those slides?
Yeah, of course. Yeah.
Okay. And then the second question is on the navigation centers. If there's only one, is there transportation to the navigation centers for other locations?
We're gonna have to figure that out. I mean, I know that's an internal conversation that we've been having, right? But we don't have a formal plan to do that, but my intent is to try to do something, because I think that what we don't want to get into is individuals that do have transportation barriers and they're able to navigate to like the West Sacramento site or the Davis site, right? And so I think it's a bit of a resource issue, and we just need to figure out how that might work. But ideally, I think we'd have like a van or something like that that could go out to the sites and bring people to the Woodland site, right? So we have not committed to anything like that yet, but it's definitely you're thinking the same thing that we're thinking.
Okay.
Just from a data set perspective, like as I was going through, you were walking through it, I was finding myself trying to add up the numbers. And so just some consistency, because I think there was something that presented in quarters and then something biannually.
Yes.
Those big numbers are always more impactful as you're trying to advocate for the saving of programs. I would look at it that way.
Yeah. Well, touche. The problem is with the data being reported to us, right?
Yeah.
So we had some providers reporting quarterly data. We had some providers reporting biannual data, right? So, but yes, in the BHSA plan, I would like to have like a different data collecting mechanism that helps kind of, because when we were having those conversations about the NHSA budget earlier in the year with the board, trying to compile that data set and trying to compare apples to apples was just like very difficult. So, but I agree with you on that. Thank you for that. I guess I don't have to respond to everything because you guys are just giving me feedback, right? Okay.
It's up to you. It's up to.
Okay. I'm happy to.
Any other questions? 50 data questions?
The navigation center numbers, are those broken down by residents, or do you have a breakdown? Because you could have a resident of Davis comes here as opposed to going to the Davis, or it's just went into that location.
Yes. Yeah.
Okay.
Yeah.
We don't know what the needs residency is then.
Yeah. No. I mean, but yeah, I think that there is a way that we could pull together data about where clients that we're serving live, right? I just don't know how useful that information will be to us, right? Because if someone's in Davis and they're already coming to Woodland for some reason, then, then that's kind of what's happening.
Yeah, but that, what that does tell you is that won't be a transportation need necessarily. What you need to find, why, the reason you need that data is so you can estimate how big the transportation demand is going to be.
I agree. But what I will say is that in terms of the best use of whatever funding and facilities and resources we have is that if we're only going to have one clinic, right, that Woodland is
Right.
It's our main campus, right? It's also the biggest building, right? And so, but I get your point.
No, it's it's a crosstab. It's not something that's going to be difficult to do.
Sure.
Okay.
Yeah.
I mean, the computer can do the crosstab for you.
And I don't know if it's a cross tabulated, but I'm sure we could get that data.
But I'm just saying that's
I wish it was as easy as you're saying, but but I get your point.
That's what I did for other things.
Okay. You must have had a very well organized data set.
I would also say this is not easy information to deliver. And I think you did it in a very concise way, without like hiding some of the facts.
Yeah.
Which I think is important for this board to see and hear. And I appreciate that.
Thank you.
A second. All right, any other questions before we move to the director, Tony's report? And before we do that, I just want to remind people, mostly for public comment, we're going to open up public comment, but that Tony does not address every, he does not give a report out on every item on this, is that basically we'll pull off from these items and ask Tony, we will ask Tony specific questions related to that. So this isn't a report out that he would give if you have a specific question. Then you just fill out what you want, either A or B or whatnot, and then Tony will, and then we'll go in order and you can ask Tony your question related to that.
Publish response to the,
I was just gonna go for public comment. I will go for public comment. Then he could address it.
Yeah, no, I just didn't know for the purposes of the hearing if we needed to give.
Oh, and then I guess
public
that's-
a chance to respond.
Do we need to, Christina, or can we go right to public comment and ask people to give their response in public comment?
I think that, and I apologize, maybe I should have said something about this earlier. I think like in the Brown Act stuff, you say, we're opening the public hearing, right? And then it was the thing, and it's like, does anybody want to make a comment? And then like, if people talk, they do, and then at some point you go, we're closing the public hearing.
Okay.
So we need to do
True,
public
yeah.
response before.
Okay, so we'll go
I
back to the
think-
public response and then we'll go to public comment. Got it, thank you. All right, so we're opening it to public response.
Which was already included in your packet.
Right.
Yeah.
Oh.
This one feedback we received.
I thank you for that. And,
Yeah.
and I should have commented on that, and I forgot we removed that slide, but I was going to verbally comment on this, that we did receive one piece of public comment from Nami Yolo that was that had positive feedback for the county, I guess, and like that looking for continued partnership in the future. But that was it. We only received the one for the 30-day public comment period. We only received one public comment.
Okay, so we're saying that there's no public comment right now on the hearing.
If anyone online
We're
would like to
asking-
make a public
we're
comment,
asking-
then this is their time before we close the hearing.
Yeah. And then just, you then get back to NAMI, you give them a response.
I don't know that that's how it works. I think we just include that, we exclude that and we include that in the report to the board and to the board of supervisors, and it's included in the information.
It looks like Donna would like to share.
Great, Donna, hi Donna.
I can respond to them, like, thank you so much. That was so nice of you.
Hi, everyone. Thank you. I wasn't planning to comment, but thank you for the great presentation, Tony. And I'll just add here that, even though we had to take a 25% cut in our contract with the county this year, we're just really appreciative of the time that county staff spent with us. And I know that they worked very, very hard on, putting this really challenging puzzle together. So I just want to thank you for all the work that you do.
Thank you, Donna, and we appreciate you too.
All right. Thank you, Donna.
And don't take this the wrong way, but you look like a work of art. I don't know, like on our side, it's like it's very,
It started today about 2:00, or no, later today after a really long, intense meeting. All of a sudden, I'm all blurry. I don't know what happened. Yeah.
Okay. All right, anybody else reaching out to you, Christina?
I don't see anyone else.
Okay, so we're gonna close the public hearing.
Oh, here comes Emily.
Oh, Emily.
That was a mistake. Sorry.
Okay. All right, but now we're going to move to public comment with respect to the next section, which starts with the behavioral health director report out. If anybody has comment from the online.
Don't see any.
Okay, great, thanks. Okay, so I'm going to ask what letters people want to pull off to ask Tony a question.
See,
Okay. Anybody else?
and I'd actually suggest maybe drop K in the future, since that's kind of.
Yeah.
Okay. BC. And probably take leadership transitions too, I guess.
Yeah, yes, sorry about that.
That's okay. Okay. Anything else?
Well, you can probably take I off too. I wanted to hear
H, okay.
Okay.
Okay, so I have on my skill card, B, C, H, and
So, B, C, D, and H.
oh, B, C, D, and H. Okay, D. Okay. All right. So B, MHSA annual update.
They're going to ask you a question.
Oh, I'm sorry about that.
That's okay. It's good news.
I forgot
That's
that
okay.
we changed the format. Yeah, sorry about that.
Together will work. Okay.
So I just have a question about the deficit, the preliminary breakdown. The 4 bullets, what is the reduction of county behavioral health programming of 2,600,000? That's like a huge bulk of it. Would that be like the crisis or the centers?
The crisis navigation centers is a component of it, right? So it's 2.6 million of the $4 million. And so, the crisis navigation programs is one piece. We're also looking to essentially not fill some vacant positions. So we have a number of vacant clinician positions and case manager positions that we are going to elect not to fill. And there's some other miscellaneous cuts that are in there. We're still working out some of the, sorry about that. We're still working out some of the details right now, but essentially the majority of the budget cuts are going to be absorbed in reducing the staff, essentially. And we're not anticipating a need to let go of any internal staff necessarily, but we have some vacant positions. Now, I will say that there are some programs that have also been identified for elimination that do have staff in them, and we're working with the board on or not work the board. We're still waiting to see kind of what direction we're going to get about them. So we were proposing to eliminate the cultural competence program and the early science training assistance program as well. And that would basically be the entire programs, right? So the biggest pieces, right, are the cultural competence, early science training and assistance, staff, not filling vacant positions, and then reducing the clinic down to one clinic.
And reducing down the clinic, does that also reduce down positions as well?
No, we would take those positions and bring them in. We would reallocate them to other programs. Yeah.
Thank you.
Thank you. All right. Please, let's see.
Let's see. For the RFP process, quite often have a board member participating in the evaluation of the RFP. You're talking about is kind of internally not going through that for the first year that they give it out.
In terms of, and again, like with trying to potentially transition existing providers.
Do you get a board representative to participate in that?
I think that would be good.
Yeah.
Well,
is that something that would be?
I don't know. I mean, it is definitely something we would offer to the board to participate in that process.
I don't know if that would be a number of different areas, if that might be broken down for different board members for different areas, or you just want one. But we probably need to figure that out.
I think that, yeah, maybe I can meet with the executive committee and kind of talk through what that kind of how much assistance we would be asking for with that. Yeah.
Okay. That was just my question.
Yeah, no problem.
Right. Dee, why did you pull me?
Yeah, just if there's any updates.
You'll get a sneak preview. Let's see. So we're going to be making a presentation to the board on next Tuesday, where we're talking about moving forward with one of the, as you guys may remember, a few months ago, we went back to the board and said, hey, we don't have enough money to do Crisis 2.0, but we'd like to move forward with a 1-year pilot. We're exploring 2 different contracts with 2 different providers. So one of the providers that we were looking at that is within Yolo County, we're not able to contract with them for this purpose. And the reason is because their licensing with California, with community care licensing, will not allow it, right? They're part of the Crisis Now continuum, and it's safe harbor, right? Essentially, so their specific type of licensure will not allow them to do like the behavioral health residential crisis, or I'm sorry, the crisis receiving, right? Because they're supposed to be like a more of a longer term facility, so they can't just have people kind of coming in and out. But the other dilemma that was coming up is that there needs to be a medical clearance, and that sort of defeats the whole purpose, right? But we are confident that we can move forward with our contract with Wellspace Health in Sacramento. That's a facility is located in downtown Sacramento that provides the same type of services that we were hoping to provide with Crisis 2.0. It's a facility that's operated by Sacramento County, and they had graciously agreed to allow us to contract for three beds. So what we're going to be presenting to the board is, this is an option that's available to us, and we'll be asking the board for direction about whether or not to move forward with this as a 1-year pilot or not. If the board was to elect to direct us to move forward with a 1-year pilot, there's some transportation and some case management coordination that needs to be sorted out. And so what we would be proposing to do is to have one FTE clinician that would be kind of responsible for sort of helping with some case navigation and linkages to resources, and then also kind of starting to work out the transportation piece, because we might potentially be getting individuals in the rural part of Yolo County and bringing them all the way to downtown Sacramento. So, but we're confident that we can navigate that. We're hopeful that the board will approve for us to move forward with this, even though it's not at the scale that we always wanted. It is at least something, right? I think that it will help us to establish like a workflow and get a better idea about the potential for it, while we're also looking at some potential solutions for having a permanent facility. One of the big challenges really is about the actual price tag of this. If we're to do it, kind of quote unquote the right way. And so, while the pilot is going on, I think we're going to continue to look at how we might be able to shore that out.
And I would say, well, it's hard that it's not within the county. Like I remember a time where this was totally off the table. So I do kind of appreciate that we're going to get something.
Yeah, what I'll say about it is that this has been a topic of conversation since I came here 6 years ago.
Yeah.
And I think that conversation predated me, right?
It was never completely off the table, but it was hanging off the edge.
It almost was off the table. And then we did like a letter,
Yeah.
which resurrected it a bit.
Yeah.
Right. But I think that this really sort of illustrates the challenge with getting this put together, right? But I will definitely give credit to our agency director, Monica Morales, right? Who, when we were kind of looking at like, okay, well, what do we want to do here, right? We have 3 beds, right? The crisis 2.0 was 8 beds, and there was a lot of concern that wasn't going to be enough, right? Monica was really adamant about like this is a service that can still provide assistance to some Yolo County residents, right? So it's something we need to move forward, right? And so part of it is like it doesn't feel great to come and say, okay, this is what we got, right? Like these 3 beds in another county, right? But at the same time, it's the right thing to do, right? And so that's what we're trying to do, and we're hoping that we can build off of this.
Right, and I think it's important that, our annual report, right, that, that's the time where we can also make recommendations. We can certainly send letters, which I'm not opposed to, but I also want to remind us that we haven't done the annual report in a while, so we kind of, I don't forget the right word, but that is really what we're supposed to be giving our recommendations. And so, in January.
The annual report is when you get, I was just thinking like if he's gonna go and say something to the board, I know Jonathan will he would recommend us making an action, give them a letter, a support from the board. We've done that in the past.
For prices now for more beds.
For those 3 beds. I mean, it's music to my ears to hear something. I'll take it. 1 bed, 2 beds. I'd love to hear that.
Yeah, I mean, if you feel like you need, we can do a letter. I just don't know if we'll get it by.
I mean, I don't want to show my hand, but like I'm pretty optimistic. I'm pretty optimistic.
Okay, this is good.
I mean, I can't speak on behalf of the board, right? Obviously, but I'm optimistic, and I feel good about this. But again, it's the board's decision, not mine.
I mean, I think I want to congratulate you if you worked to try to come up with something in the face of some really daunting circumstances. And
I mean, I certainly cannot take all the credit, right? I mean, we have a team who was working really hard on it, and I mean, the interim director, Joan Planell, when she was here, kind of started launching this. It also helped that we got some context. So Robert Villarreal, who's one of our clinical managers of our crisis program, who was here presenting tonight, he had like kind of like a connection there too, you know what I mean? So it's definitely it was fortuitous that we had the right people here at the right time to make something happen.
Could this maybe be an attempt for the next round of innovation proposals?
So, I don't know. I mean, maybe, right? I mean, I know that there's no dedicated innovations funding. in
Yeah, I
the
know.
HSA, right? You know, and so you kind of get into a situation again where we're trying to identify what the community's priorities are, right? You know, so we would, if we're going to do an innovation program, my understanding of the new BHSA rules is we'd have to take.
It'd have to come from something.
It'd have to come
That's
from
what I,
something,
that,
yeah.
that was what I wasn't clear on.
But I
I
also.
thought they had a pot somewhere.
No, not necessarily, but I mean, I think that I mean, again, I don't want to get too far ahead of myself, but I believe that, you know, if the community is prioritizing this enough, I mean, there may be justification to use BHSA funding for this purpose, or, you know, a different funding source. I mean, honestly, we do feel like, or I do feel like, I guess I should say, you know, personally, that there is, buy-in from the cities and the hospitals, right?
Yeah.
You know, that they've kind of been saying like, hey, look, we're here for this, right? I mean, now the cities are going through their own versions of their financial challenges as well, right? But I think that, you know, I don't want to get too far ahead of myself, right? But I think that there is a way for this to work that doesn't rely completely on behavioral health funding, right? The other thing that we might seek to do in a future rendition of this would be to do something similar to like Placer County has, where they have they have a behavioral health receiving center where they dispatch their mobile crisis out of that, right? So then you're putting both, you would be putting both programs together, right? And then you're able to kind of like leverage the cost of both programs, right? So.
And then you can buy in from the acutes as well, much easier, yeah.
Possibly, yeah,
I mean,
you know, so.
Trailer side of hospitals.
Right, so I mean, I think that this feels kind of like a foot in the door type of approach, you know, at some point of like, okay, we have it, right, you know, and so I definitely have been reluctant to take on like one-time projects, right, or to advocate for them, just because you know, politically, I think you get into this whole situation, we stand up this project with one-time funds, and then at the end of it, everyone's like, great, you're gonna do that forever, right? You know what I mean?
Yeah.
And then that is,
Then you're stuck.
that is a challenge, right? You know, but in this case, I mean, this is something that the community's been saying they've wanted for a long time, and it's something that kind of has been acknowledged, like, well, we do want this here forever, right? And so, you know, hopefully this is a good first step.
I would also say leverage your partners to help get data around the successes for the program to kind of build in those additional things.
Yeah.
Everybody loves Plasters. I mean, there's tons of data.
Well, yeah,
It's
Placer,
expensive.
yeah,
I
Placer's,
guess you have more money.
yeah, they got a good thing going on up there.
Yeah, they do. And they have a, yeah, oh, right. Anyway.
The other thing I wanted to clarify, so the beds operated by WellSpace in Sacramento, those are not 5150 capable.
No.
Okay.
Yeah, they are not, it is not a crisis, it's not a CSU.
Okay.
Yeah, it's not a crisis stabilization.
So essentially, as it stands, even when this new system is stood up, there are people that are still going to keep getting funneled through the ER.
I mean,
So yes.
I mean, I think. I think that's the point of the pilot, is to find out, right? Is to kind of get a better idea about, okay, how does this actually work, right? And really inform future efforts.
Yeah, but I agree with kind of what you were saying, as in any beds that are like moderate or moderate level, kind of good development, right?
Yeah, and I'm gonna make another plug for the annual report because it's coming up. And so I think these are all great things for us to look about, and because we really wanna, where we wanna put the teeth to our recommendations, we can certainly do letters. I'm not saying we wouldn't, but I think also it's our opportunity to present to the board.
We read it, so we're gonna address
what we
it.
really think, and especially it's aligned with what we're hearing in the community. So when you come back in January, there'll be hopefully an annual report for you all to look at. So I'm just planting a seed for, I want to look at that in January.
We need to vote on the, how much you say?
We've got a point of procedure in the comments up there.
Good, sure.
Do you want me to comment on this last one before you go back to that? Or
Yeah.
there's a question about age.
On,
You had age, I think you pulled children's services.
children's system
You
of
had-
care.
you had-
Yeah, oh, age.
you have a question.
I was hearing age. I was like. But from children's system, of care, okay. And the one question I had about that, is this contract that was executed taking into account that you had to basically cut everything by 25%? I just wanted to be clear.
So this particular contract was funded by grant funds that are connected to the
Okay.
Financial School Partnership,
Okay.
right? Yeah, so.
Okay.
No, right? I mean,
Okay.
so, I mean, essentially, so what I can tell you is that it was part of the plan prior to us starting to have these conversations, right?
Okay.
And it's really not, I mean, I can get you the figures. It's in the grand scope of the things that we're funding, it's not the biggest contract we have, but it's not being funded by MHSA dollars.
I know it's not the biggest thing. I just didn't want its effort to be diminished further by.
Oh, no, yeah, no. I mean, we're, so, I
That was
mean,
all.
so we're very,
Motion to.
we're very hopeful and optimistic that this is going to help us to obtain revenues that we have kind of been passing on,
Yeah.
right? Yeah, yeah.
Okay, great. All right, so I'm gonna go back and, would somebody like to entertain a motion to support the NHSA plan that Tony presented?
I move to support the NHSA, NHSA plan that today's going with.
And I will second. And my laugh. All right. All in favor?
Aye.
Okay. Okay. All right, I know we're running tight on time. I know, Cynthia, you had a document that you shared with everybody. If you want to just give your
Yeah.
walking.
Yeah, so the site visit committee, the ad hoc committee has been meeting, and we've been really trying to get our running or hit the ground running, I guess. And so we were trying to plan our first site visit to Safe Harbor. We're in the works of making that happen, but what I passed out, and if you didn't get a copy, there are some on the side table still. It's our new revised site visit guide. I just wanted to provide it as a reference. All the documents and stuff that we're also going to be using in the site visits are in there. But if outside of this meeting, if you look at this and you have any feedback, that would be much appreciated. So please feel free to email me. But essentially, we want to start our first site visit to Safe Harbor, and we have a bunch of different documents and stuff in there that we want to kind of use to guide our visit there. So I just wanted to kind of provide that update so we know that it's happening. We're going to get our site visit.
If you have any feedback, you can actually send them all to me. I'll gather them and share them with Nick.
And then we'll approve them in January. Okay. A quick update.
Yes, annual report committee has been, annual report committee has been meeting. We're in the process of creating annual report. We'll have it ready for board approval in January.
Awesome. Yay, nice work, Kimberly.
And then one more thing I have to say. First site visit, we're going to keep it within the committee and then we'll come back and report on what we find. But I just wanted to kind of get another count to see who exactly was interested in being in the ad hoc committee.
Okay, Kristen.
Thank you.
Also, and then I'm not sure if Emily, I've got who through the supervisor, if Emily's going to be doing the supervisor report or.
There she is.
Yes. Hello. So very short report. Tony covered most of it, but I'll just repeat some of it, but it's going to be real short. So to follow along with Tony's update, providers did share that they'd rather no cuts, but 25% was the least disruptive to care. And so that's the path that the board ultimately chose to take. The latest behavioral health funding proposal recommended, Tony covered this too, closing the Davis and West Sacramento navigation centers, leaving only Woodland, but the board did request staff to review the client data, which it looks like Tony has done and the staff has done since the last meeting, before finalizing that plan. One full-time Woodland site might work, or residents may be better served with multiple part-time locations or a mobile option. So I'm assuming that's going to be addressed further. And the board also stressed the need to improve Medi-Cal billing capacity to strengthen revenues. And Supervisor Frericks and the board really do appreciate the local behavioral health board's input as we all navigate the budget decisions that are going to be very challenging over the next few months and years. And that's it.
Thank you, Emily. Appreciate it. Okay, if there's nothing else. Meeting's adjourned. You guys have a wonderful, safe, enjoyable New Year. We'll see you next year. You too. Thank you.
I know. Tony, Christina, you must have wanted us something.
I know. I was gonna write a note on it too. It's all yours.
I was like, what am I asking for?
They're, yeah.